righty, well, welcome everyone to the latest webinar for ASJ GEMS Global Educational Meetings. I'm your host, Phaedra Kress. I'm the Executive Director of Journals for the Aesthetic Surgery Journal and ASJ Open Forum. And I'm really pleased to have our guest today, Dr. Grant Stevens. He is the founder of the medical director of Marina Plastic Surgery and Med Spa in Marina del Rey, California. He's been the chairman of U.S.
I lost. She froze.
I'm just going to mute you one quick second. Okay. The USC Division of Aesthetic Surgery. He's a past president of the Aesthetic Society, an active member of ISAPS, and he's on the board of directors and has been an invited visiting professor at numerous US and international universities. Dr. Stevens has authored more than 60 articles and chapters on aesthetic plastic surgery. He recently completed a chapter on mastopexy augmentation in Grab and Smith. He's represented our aesthetic community in a variety of forums and is widely seen as a key opinion leader. He's been interviewed for articles that have appeared in USA Today, People, The Wall Street Journal, Beauty, Forbes, Glamour, Vogue, Allure, and many others. He's appeared on more than 125 television programs, including CNN, Discovery, 60 Minutes, and MSNBC. He's now he now features his own podcast called The Technology of Beauty, which highlights the movers and shakers of our aesthetic industry. So without further ado, I welcome you, Dr. Stevens, and we look very much forward to hearing your talk about drainless tummy tucks.
Well, good morning, everyone, and thank you very much, Phaedra, for having me. I'd like to thank you as well as Fuad Nahai for the opportunity to share some of my thoughts about drainless tummy tucks and optimizing tummy tucks. But I also would like to thank Dr. Justin Perez, who's here to my right, who has been my fellow this year and who's helped me do this and will be joining our practice here in the next couple of weeks, as well as thank Dr. Dan Gold, who was helpful in putting this together also and also publishing our thoughts about drainless tummy tucks. You know, when I first started doing drainless tummy tucks, I thought it was all just the pursuit of eliminating the drain and the hassle of the drain and the pain of the drain and so forth. And now, some 10 years later, I'm convinced it's way more than that. And I hope that you stay on and I can share some of my thoughts with you, because I now believe drainless tummy tucks combined with progressive tension sutures are the standard of care and do result in the best looking post-operative abdominoplasties. And hopefully I can share some thoughts with you and convince you of this, and you'll give it a try if you aren't doing it yet. Hold on one second, I'm trying to advance. And there we go. Oh, let me go back one. So these are my disclosures. I don't think I have any conflicts whatsoever as it relates to this. There was a wonderful article, I'll show it to you a little bit later also, that was written in the Aesthetic Surgery Journal about the redefining abdominal anatomy and the 10 components or elements for restoring form and optimizing a great looking abdominoplasty. It's way more than simply a paniculectomy and slicing off the excess skin, as all of you know. There's so many other parts to an abdominoplasty, including muscle repair and liposuction. But when one really refines it and looks even further, there are other issues like the abdominal design, the abdominal contour, scar placement, and so forth. And I'm going to touch on these in a few moments, because I think progressive tension sutures coupled with drainless tummy tucks actually optimizes, as I've said. Patients hate drains. Every time we did questionnaires, the #1 complaint post-operative abdominoplasty patients had was the pain and the hassle of the drain management. So managing it at home and then subsequently removing it in the office. Patients hate drains. However, surgeons put them in because they believe the seromas are lowered because of them. That's what we've all been trained. In fact, it's not correct, as I'm going to show you. Other considerations, obviously, when you start looking at abdomen, as I've talked about, is contours, but also scar quality and location, as well as compromised vascularity to the skin or leading to skin necrosis or poor scarring. Now, the concept of progressive tension sutures and the potential use of not use of drains was popularized originally and written originally by a father and son team, doctors Pollock and Pollock. They subsequently published in Aesthetic Surgery Journal 597 consecutive cases without drains. And notice when they did this in 2012, their seroma rate was listed as 0.1%. Subsequent to that, another father-son team, Antonetti and Antonetti, John and Alfred, also published a study in our journal in which they documented 516 patients, and 58 of the patients had no drain, and a seroma rate of 24% with the drains and 1.7% without. Subsequently, there have been multiple papers that have been published about drain-free abdominoplasty and progressive tension sutures, one of which was a paper that we published here in Marina Plastic Surgery. You can see the authors. And we looked at 451 patients, and in this study, it was a retrospective analysis. It was a 7-year period, 451 patients. We compared the 127 without drains with the 324 with traditional with drains. And what we found, well, I'll show that to you in a moment. This is our technique, standard abdominoplasty, undermining up to the xiphoid. We don't go wide out laterally superior to the umbilicus. And then subsequently, we put in these progressive tension sutures, and this is really key. And we start in the midline, and we work our way down from the xiphoid down to the umbilicus, and then the perimedian. We also put in sequential sutures, and the assistant is in the left upper quadrant, pushing caudally or downward and inferior caudally, advancing the flaps. A couple things happen when we do this. It's way more than just obliterating the empty space, which is what I originally thought. We're actually advancing the flap, and allows us to resect even more skin than what our preoperative plan was in almost every case. So it allows for more excision of the skin, which also allows us to lower the incision in people that have mild to moderate abdominal excess or panniculus. So that's one advantage. The other thing is it takes tension off the scar, and we see less scar widening, less scar thickening, and also less migration in a cephalad direction. So these progressive tension sutures do far more than simply facilitate the eradicate the empty space. And as I mentioned, the assistant is very important. And we use a dissolvable suture like O-Vicryl. And every now and then you grab a little bit too much and you pucker it, and you just take it out. You look at it, you take it out, and then you just do another one. And every now and then someone comes in post-operatively and has a little pucker, and you reassure them that that's going to go away because it's a dissolving suture. Or you take a 14 or 16 gauge needle and just put it through the skin and swing it laterally, and the edge, the bevel of the needle cuts the suture. I have never had to go back in and reoperate for a pucker. The other consideration many of you have raised is the time it takes. And it turns out on average, it's about 12 minutes now when we time this. The range can go up to higher for sure. And when you're starting, there is a learning curve because you end up pulling out a few more of the stitches. But when you get used to this, it adds about 12 minutes. And I would argue you spend more than 12 minutes talking about drain management and removing the drains subsequently in your office and so forth. So I think that the time consideration is not one needs to be overly concerned about. As I mentioned, we start from the xiphoid, work down to the umbilicus. We've already done the diastasis repair, and we have not resected the flap yet, the redundant pannus. We used to do that, but then consistently I'd have to go back in and take out more of the skin because of the advancement of the flap. So now we advance the flap, continue all the way down, and from here we do the perimedian. We go all the way down And then we draw the redundancy and then excise it. And as I mentioned, it allows us to remove more, as well as secure the caudal flap to the pubis, and also secure the cephalad flap that you're advancing down. And so that stops scar migration and leads to, as I mentioned, more excision. So here's a little diagram that came from our article, the first article we published, and it gives you a feel for the paramedian sutures. And we do 2 rows paramedian, and then we'd go laterally also to obliterate the last parts of the dead space. Now, as you know, there are anatomical differences between the male torso and the female torso. Most of the tummy tucks we do are on females, but we find about 10 to 12% of the tummy tucks we're doing are on males. So knowing this, one needs to keep in mind the angle of the abdominal insura, as well as the width of the rectus. If you do a typical female and then you go to a male, you don't want to feminize the male abdomen. So you want to keep that in mind. This paper I was talking about earlier, redefining the abdominal anatomy, 10 key elements for restoring form in abdominoplasty, is really a wonderful article. If you haven't read it, I encourage you to read it. In this article, he points out the different anatomical differences, the finer parts of a attractive looking abdomen. Excuse me, I'll go back up. And the relationship of the various contours to what we can recreate with progressive tension sutures. It's not just a flat surface anymore. It's not just simply a paniculectomy, but it's actually sculpturing the abdomen with internal progressive tension sutures. And the results we get are beautiful. Here's one such patient, just a standard patient that we do, and you can see the contours, the flat abdomen, the linea alba, and so forth. Now, many of you believe that you put in drains to stop seromas. This was our first paper, and notice that our seroma rate of the 324 patients was 9%. The seroma rate in the progressive tension sutures without drains was 2%. And this was our first paper, and this was statistically significant. Now, we're not the only ones using progressive tension sutures, of course. Many of you are using them to obliterate dead space in your abdominal flaps, latissimus dorsi, perforator flaps, and so forth. They certainly come in handy, and we've been using them now in a number of other applications. We did a study with the tissue glue along with Joe Hunstead and some others, and we compared our seroma rate to abdominoplasties without drains. And actually, we had very favorable results, except that we had a higher seroma rate when we had tumescent anesthesia coupled with liposuction. So when we compared tissue glue and a straight abdominoplasty with drains with a standard abdominoplasty with no liposuction, we had similar seroma rates. However, as you know, most abdominoplasties have some liposuction associated with them, at least in our studies and in our patients. And when we looked at that, we had a higher seroma rate. So we don't use the tissue glue. We do use progressive tension sutures. That is especially when we're doing liposuction. So Dr. Gold and the rest of us and our team here in the Marina published a subsequent paper, and in that we looked at 619 consecutive abdominoplasty patients, and we looked at the seroma rate just to see if it actually changed as a function of liposuction and try to tease out that data. And we found that in fact it didn't. That with the progressive tension sutures and no drains, our seroma rate remained 2.6%, which was statistically lower than the 9%, or actually up to 9.2% when we did lipo. So again, this is why we don't use the glue to do this. The other reason is I did a 66 of them with glue, and you can't advance the flap quite as much. You're holding down, and I'm not anti-glue, but I can't get the same results with the glue that I can get and we can get with the sutures. So as I mentioned, the seroma rate is lower. PTS or progressive tension sutures without drains lead to less seromas. It can be combined with other procedures. Liposuction does not increase the seroma rate. And I would encourage those of you that are listening who are skeptical, and I know many of you are, I would encourage you to give it a try. I'd also encourage you, if you want, to come to the marina and do it with us. We're happy to do it. We've also videotaped it. It's a little daunting at first, I know, but I encourage you to give it a try or call one of us, Dr. Perez, Dr. Gold, or myself. We're happy to walk you through it. And I'm firmly convinced that if you do this, you will have better looking results, happier patients, a lower seroma rate, and you'll be very happy with it. And the fact is, even going back to Ralph Millard when he wrote this, and going back to Gillies, and remember when in the Ralph's book, when he was talking about the principalization of plastic surgery, to honor that which is normal, return it to the normal position. Traditional tummy tucks without progressive tension sutures are not heeding that advice. It's simply a paniculectomy. But by including progressive tension sutures and creating that beautiful contour of the native abdomen, you are returning things back to normal. Here is an example of someone in which we combined medium definition liposuction to sculpture a beautiful hourglass hips. If you can see, we took down the hips and flanks as well as the abdomen. We routinely suction the abdomen, and you can see the linea alba is beautiful, and the semilunaris is beautiful. You can see. I was pointing, but you can see a semilunaris there. And again, that's because of the progressive tension sutures and restoring a beautiful feminine contour. So once again, it's not just to prevent seroma or eliminate the use of drains. In fact, it's to have the best looking tummies you possibly can do. We're sitting here in beautiful Marina del Rey, California, right by LAX, which is in the background of the shot. We're here at Marina Plastic Surgery. And as I mentioned, we're happy to share any of our thoughts with you. Just give us a call or contact me or Fedra. And Fedra, I want to thank you once again for this wonderful opportunity to share some of our thoughts with your audience.
Well, thank you so much, Grant. That was fantastic. And we have several questions in the chat box that I'd like to get to. I have one or two of my own, some of which you've actually already covered. So I'm just going to run through a couple questions and encourage everyone who's on the call to ask us questions in the chat box. We'll get to as many as we can. We do have a good bit of time for Q&A right now with Dr. Stevens. So, sutures.
I didn't hear you. I'm sorry. Could you try it again?
Sorry. What are your preferred sutures?
So for the progressive tension sutures, we typically use Ovicryl.
Okay. And how many do you usually place for an abdominoplasty, tummy tuck?
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Yeah. At the most, maybe 14 or 15. I'd probably average 11 or 12.
Okay. And feel free in the chat box, everyone, if that's about what you're seeing, go ahead and comment. You can let us know how many you're placing. And are those interrupted or continuous stitches?
Those are interrupted. We close the diastasis and do whatever muscle repair we need to do or any hernia repairs. And then at that point, we start in the midline and then the paramidline. And then as we get to the very distal portion below the umbilicus or caudal to the umbilicus, we then are probably putting in maybe 4 across 5.
Okay. And you mentioned dimpling. Do you see dimpling often? And if you do, how do you deal with it?
Say that again.
Dimpling, do you see much dimpling, no dimpling? And if you do, how do you deal with it?
Yeah, occasionally we'll see dimpling. And if it's enough that concerns me, I'll just snip the stitch out and then put another one. I always, we advance the flap, we put the suture in, we tie it, and then I pull the flap down and I look. And if I see dimpling, I will take it out. Now, having said that, though, oftentimes the next morning or as the swelling goes down, I will see evidence of a slight depression, a dimple. And as I mentioned, it typically goes away just because the suture dissolves. But if it's bothering the patient or bothering me, I'll take a little needle, I'll go through the skin and swing it back and forth and simply remove the suture. It's simple. And the key point is we've done well over 1,000 of these, and I've never once done a revision for a dimple, not a single time.
Well, that's fantastic. So on the same point, you mentioned that it's about a 12-minute average that you're adding for using progressive tension sutures. So, obviously that's your average, kind of finely honed and tuned after years and years of doing this. What would you say for the novice? How many minutes would you say this would add? And do you have any advice?
I'm going to turn to Dr. Perez. I have a number. I'm going to turn to Dr. Perez, who started doing this with me. Wow. I was going to say 20. I hate to admit it. Okay, 20 to 30. Okay, he said 25, but I'd say 20.
20 minutes. Okay. So that's good in terms of setting expectations. Now, let's see. I'm going to.
And again, the assistant is really important. That's the single most important variable, because you can become very agile at doing this. But if you have a crummy assistant who's going sideways or not pushing straight down or not giving you the adequate depression and tension, you will slow you down. You can still do it. You could even do it without assistant if you had to, but it would take you a long time to do it. There was a question I saw about medical legal considerations and not stating a standard of care. I want to be very clear. I'm not stating this is the standard of care in the community. If a person wishes to use drains, that's been the traditional way, and it's been tried and true. And if a person chooses to use drains, that's fine. I do believe at the same time, without taking the standard of care doctrine, and I'm intimately familiar with the medical legal concept of standard of care, it is optimization. Just like one can do facelifts many different ways, and we all have our own philosophies of the best way to do a facelift, they're all within the standard of care. However, I happen to believe certain types are optimal, and you have your own opinion. I've presented to you my thoughts over the years on abdominoplasty, and while it's not the standard of care per se, to the exclusion of the others, this is the best way to do a tummy tuck. And it does result in the most beautiful abdominoplasties and the less amount of revision surgery and so forth. And I believe it's possible this could become the standard of care in the next decade. I don't know, and I'm going to stay well away from that argument. What are the questions? Is the plane of dissection superficial or deep to scarpas? Deep to scarpas. So the stitches are going from, the stitches include scarpas as well as subcutaneous fat, and they then go down to the abdominal wall fascia.
Now, before we move on to the next question, I launched a poll asking, do you currently leave drains in for all, most, or rarely for abdominoplasty? 57% of you said for all abdominoplasty, and 38% said most, and 5% said rare. So, Dr. Stevens, is that what, kind of what you'd expect to see?
That's exactly what I expected. When we did this at the Northwestern Society, I think it was about 70 or 80% said all. And we didn't break it down into most. We just said, do you drain or not? And the lion's share were drained. And the interesting thing was, subsequently at the end of my lecture, I asked how many of you would consider going home and trying it. And a lot of hands went up. And then Kia, who was in the audience, said, I lost a patient to Dr. Stevens who left Eugene, Oregon and came down to Marina Del Rey just for a drainless tummy tuck.
Oh, how funny.
But we probably had 30 to 40% of the people in the audience say they'd give it a try. And I have received multiple emails and phone calls from people who said, thank you very much. I now have thrown away the drain. So to those of you who think this doesn't work, or you're afraid to try it, I'm telling you, give it a whirl, or come out here and watch us do it, or give me a call and you will thank me.
That's fantastic. Now, Dr. Jason Leighton is saying, when you say routinely liposuction the abdomen, is that just the flanks, or are you talking about abdominoplasty flaps as well?
We suction the abdominoplasty flaps as well as the flanks and hips. And I published extensively about that in the Aesthetic Surgery Journal. And there's no higher complication rate. We've compared no suction to suction of abdomen, hips, and flanks, and then just abdomen, along with abdominoplasty, and have shown in multiple studies you can do it safely, and the world does it safely. And you were sold a bill of goods if you think you can't do it.
Okay, his follow-up question is about BMI. We actually have a poll, ironically, going about this right now. So how do you handle patients with BMI, and what is the highest BMI you'll permit to do a tummy tuck? And then is there a point at which that BMI dictates you need to put a drain in?
Yeah, well, it's not really a drain question for me, but our average BMI, if you look at the study, was 24. We don't have an absolute number cutoff that I calculate and say we won't do anything above a certain number. I certainly don't decide if I'm going to put in drains based on the BMI. I decide whether I'm going to do the surgery. I'm a little stricter, I think, than some are. How high do you think Dan goes? Yeah. Yeah, that's such a good point. Yeah. There was a time where I said to myself 32, 33 was the max I would go. We occasionally will go a little higher than that. And as pointed out by Dr. Perez, it somewhat depends also on the distribution of the fat. We also work very closely with our anesthesiologist, same one we've had for 20 years. And if there are any other comorbidities along with BMI or any other questions, we just don't do the case.
Yeah,
We have a pretty tight filter. Knock on wood, we've never had a serious complication and so forth. So
it's a great point, and I polled the audience here. The average BMI they're using, let's see, the majority are 25 to 30%. That's 59%, and 30% and higher is 21%. So that reads, close to what you were saying about your 24, 25%. And when I asked, do you use tissue glue or sealants in your abdominoplasties? 8% yes, 92% no.
Again, I'm not anti-glue. I would suggest that you try the stitches though, and especially if you're not sucking, then the glue works fine. Although you're not going to get as much skin out. And in fact, if you try this, mark out your traditional excision when you do your markings for your tummy tuck. Mark it out, and what you would normally do, and then do the progressive tension sutures and look and see what happens. You're going to remove more skin because you're advancing the flap. And you'll find you'll get a 1 to 2 centimeters easily out that you didn't plan on.
Excellent. Now we're on to Todd Koch, who's asking infra-umbilical suture placement. Do you start in the midline or then progress laterally?
We do the midline and we progress laterally. And if we see dead space laterally over the anterior superior iliac spine or the lateral area there, we put him in there. And then it's not unusual to have 4 or 5 sutures down at the caudal-most extent. It really depends on how big the patient is.
Reza Momeni is asking, are most of your lipo-abdominoplasties, or do you avoid lipo in the lifted part of the flap?
Most of them are lipo-abdominoplasties.
Okay. Jason Leighton is asking, are you still using compression garment binders and how long and what protocol are patients doing for compression?
So I stay away from the word compression. We use binders to hold on the dressings. We do not use compression because it compromises the vasculature of the flap. It's snug but not tight. There's no real compression. It just allows me to keep the dressing on without using any tape on the flaps and so forth. And the next day we remove the compression garment or the garment, and we tape the flaps with steri strips or tape itself. And then we put ABDs on, and then put the binder back on again, emphasizing that we don't want it too tight. I generally squeeze the patient's forearm with my hand, and I show them, this is snug, this is tight. And I show them this, it's intended to basically stop the dressing from falling off when they stand up or walk. It's not intended to hold the skin down and so forth. That's already being done.
Exactly. Okay, Larry Leverett's asking, are there any patients for whom you would not use progressive tension sutures? Great question.
Well, yeah, that's a great question because I never say never or always, so to speak. Larry, the way I'd answer that is I cannot remember one case in the last decade that I haven't, though, that I have used a flap. Excuse me, not a flap, a drain. So would I ever? I might, but I don't know. I don't know why I would. I can't even imagine why I would. When I know that I have a lower seroma rate, significantly lower, when I use the progressive tension sutures. I suppose if the person were oozing and I had, maybe they had been on aspirin and I didn't know it and they were oozing and I had problems with hemostasis with just oozing, I can imagine a scenario where I might say, this is just too wet. But I would still use progressive tension sutures. So that's what I would do. If it were that case, I would use progressive tension sutures and I'd slip a couple drains in around them, and such that I could remove them without dislodging my sutures. I guess that would be a case where I might consider doing it.
So it's a lot of caveats to your point that it's been a decade since you've needed to do that.
Yes.
Okay, let's see. Todd Koch is asking, how do you handle the old umbilical opening if it's not resected in the lower skin flap?
I'm sorry, say that again.
Sure. How do you handle the old umbilical opening if it's not resected in the lower skin flap?
Oh, okay. Well, if that rarely happens with progressive tension sutures, because as I mentioned, we advance the flap. But if that does happen, and occasionally it does, we just close it or we tee it off at the incision. And I would say for every 100, maybe we do that once. In the last year, yeah, we did one, my fellows, one small one. Yeah, it's very, very unusual. We do more than 100 a year between us. So that's what we do. Next question. I'm not hearing anything.
Okay, here we go. Sorry, we froze a second. Joseph
Okay.
Kelling's asking, can you describe your post-op protocol and has it changed at all since going drainless?
Post-operatively, well, we inject everybody with Esperol, number one, at the time of closure, both the incision and the rectus. And we do not ever use a Foley catheter, ever. The patients can go to an aftercare, which they typically do, or home. We prefer an aftercare because we round on them that night and we walk them. Either I do or the fellow does or one of the other surgeons. We walk them around the nurse's station. We get them out of bed the night of surgery. They're almost always pain-free thanks to the Esperol. We encourage them to use the toilet normally. No bedpans. We don't even allow bedpans in the room because I want them up and out of bed the night of surgery. And the next day they walk to the car at the aftercare and no wheelchair, and they're brought to my office. They come in under their own power. We take off the dressing. We inspect the wound and the flaps to make sure everything is fine. We then put either the wide steri strips along the incision or the tape, the hypoallergenic tape. We then, if we need to put any Tramil or, we tend to the skin, the flaps and so forth, inspect them, and then put the garment back on with some gauze, and then they go home. Their caregivers take them home. Everything we use is dissolvable sutures. We see them back in approximately a week, depending on which day we're seeing patients, but it's generally about a week. The out-of-town patients fly out in a week to 10 days. We have a number of patients who fly in to see us. We're conveniently located at Los Angeles International Airport, and I have a large international and also U.S. practice. And I mention that because people say, when am I going to recover? And I say, you can recover to fly home in a week to 10 days, but you're not going to be, at the gym for a while. But we encourage walking every single day. From day one, I encourage walking. And we walk with them to show them they can do it. And we find that getting them out of bed and get them ambulated and not putting a Foley in and not putting drains in, this leads to a more rapid recovery and a better looking patient overall.
Thank you. Those are critical tips. Now, we've got a question from Peter Scott in South Africa.
Hey,
He's
Peter.
asking, do you preserve the perforators above the umbilicus?
No, but laterally. Hi, Peter. Good to see you. So from the umbilicus to the xiphoid, we're taking them all down. But what we found is over the years, the amount of dissection going laterally from the midline is less and less. So the paramedian perforators are preserved effectively from the way I was trained originally. But the other ones, they're not preserved.
Okay, can you talk to us about anticoagulation? Dimitri Masterakos is asking, what are your thoughts, and do you routinely use anticoagulants?
Yeah, well, I'll start with this. Everybody has pneumatic tourniquets and sequential pneumatic insufflation and tourniquets. So everybody gets that. And obviously we have a very tight filter of who we're going to operate on, and we don't operate on people with a high Caprini and a risk factor. But I don't use any pharmacologic anticoagulation. And I know that may be shocking to some. And I have never, ever lost a patient to a PE. I've had a few small PEs that have required therapy, minor therapy, actually. And this is over a 35-year period.
You mentioned the Caprini score. Do you have a metric for where you will or won't?
What would you say our max is? Yeah. 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 You know, we do it on everybody. Certainly if they had a 7, I wouldn't do them. A 6, I'm reluctant to. And my trusty fellow here says it's generally around 5 or less.
Okay. We've got a ton of questions, so I'm just going to kind of rapid fire at you here, Grant. We've got a question. Can you complete that? Well, I'm not sure you can do this, but they're asking you to complete the video to understand how to move from the whole midline to lateral, how to have space while closing the midline with progressive tension suture. So can you maybe verbally talk us through that, unless we need to go back to the video?
Sure. Can you queue up the video, or can we?
No, I don't think I have it. Justin might be able to. Maybe
Let's
we
see
can
if
have
we
that.
Can I talk it through while he's queuing it up? Oh, wow, that's
Yeah, of
fast.
course.
Here, hold on a second.
Okay. And while
It's so wonderful to see so many of you on this call, and so many of our friends around the world. It's wonderful. I hope you're all doing well and they're safe. We're queuing this up right now. We have other videos of this too that I should put together, and perhaps I can send them, Fedra, to anybody that wants them. This is just a short snippet of a much longer video. And you can see here, I'm standing on the patient's right. That's my right hand putting in a stitch. The assistant is standing in on the patient's left, in the left upper quadrant, really pushing down. There's already been one suture placed right at the xiphoid. This is the second or third suture. I'd have to go back and look. And I generally start in the flap and then go to the fascia. And you notice when I do that, it actually pulls the skin down, not just down as in dorsally, but it pulls it caudally. And you really are advancing these flaps. And for Peter, see how little I dissect laterally there? I did take down the midline perforators, but laterally they're very intact. And again, slipping it in the flap and then in the fascia. It's a horizontal mattress type suture, and it's tied generally with the instrument. Every now and then I'll hand tie it because it's tight. And as Fedra said, I mean, obviously, it's like anything, it gets easier with time, like riding a bike. And once you start doing this and you've done a dozen of them or something, it's just like second nature. It's a piece of cake. Was there a specific question about this, Fedra?
I think you might have covered it, but feel free to write to us in the chat box if anyone needs further clarification there. And we'll go on to the next question while we're waiting for that. Larry Leverett's asking, are the tension sutures tight enough that they cause blanching of the skin when placed?
No, no. If I saw blanching, I'd probably see puckering too. But if I saw blanching, I would cut it out.
Okay.
That's
And
a great question, Larry.
Yeah, Ken Francis is asking about TXA. Obviously, TXA is kind of a hot topic in our space. Are you using any TXA in your tummy tuck patients?
So Dr. Gold does, Dr. Dan Gold, he uses 500, right? He uses 500 and 250 bag. I haven't. Really? Okay. And when we look back at our instance of hematoma of mine, where I don't use it, and Dan's where he does use it, we've had no difference, is what I was just told by Dr. Justin Perez,
All
who
right,
trained at
thank
UT
you.
Southwestern.
Yay,
With
Jeff
Dr.
Kinkle.
Kenkel, our
Exactly.
associate editor.
Absolutely.
I want to thank Dr. Kenkel also, not just Dr. Nahai.
Oh, thank you. Thank you. So let's see. We've got a bunch of questions from someone who's
Someone what? I don't hear you. Can you? The distance between the umbilicus and the pubis. It generally was. I don't hear anything, Fedra. I can, can you give me a thumbs up if you can hear me?
I think I had a little Wi-Fi issue there. I apologize. I was saying that I wanted to try and unmute this person called EA to ask a couple of their questions because there's several that have come in. So you can go ahead and unmute if you're still with us. In the meantime, we can go to Nisha Kalra's question. How far are the sutures placed from each other, and are they random or a straight line? It looks like the question is.
Well, they're straight line on the midline, and actually they're straight line on the perimedian also, creating the semilunaris depression. The distance between them depends on the patient, but I'd say it's an average of 2 to 3 centimeters.
Okay. And Mohammed Azmi is asking, with your abdominoplasty with para-umbilical hernia, when you go to use Prolene mesh, are you using PTS alone without drains, which I think you're going to say yes to, no drains?
So I have fixed many hernias. We rarely use mesh, but your assumption is it's requiring mesh on a periumbilical hernia, which again, I would suggest is not that common. And we generally don't use Prolene mesh, but I understand your concern if you use Prolene or permanent mesh. But the fact is we do not drain in that situation. I wouldn't be critical of anyone who did though, because I understand where you're going with that. But I would encourage you to not use Prolene mesh and not to use mesh just to fix it.
I think Phaedra is frozen, but I'll jump in and I'll read the next question out loud. Which is the distance you leave between umbilicus and pubis? Does it affect the number of PTT in this area?
So the umbilicus sets that distance itself. It's funny you asked me that because we had a fellow here who measured that over and over and over. And he came up with a number. I'm racking my brain what the number was because it kept coming out about the same. But I let the patient's own anatomy determine that. We mark where the umbilicus is and we just transpose it into the abdominal flap. We're not a slave to a measurement from the umbilicus to the pubis, but it's remarkable how many times it's the same number. I just can't remember the number. Do you remember? It was a fellow. Yeah, it was I can't remember the number, but again, I don't set it for that reason. And the other question you asked about the distance between?
Yes, I'm seeing distance between umbilicus and pubis. Does it affect the number of PTT in this area?
Of course, a taller patient, if they have a longer distance, they're going to have a few more sutures. A shorter patient is going to have a few less because it's the vertical distance from the xiphoid to the pubis that determines the number of sutures.
And do you ever need to elevate the flaps laterally, like after a huge liposuction from flanks and lateral abdomen with skin laxity?
No.
Okay. Let's see here.
If that were the case, I would turn the patient, I would do a circumferential body lift. If there's that much extra skin, I will do a belt lipectomy or circumferential body lift. And we do that frequently. And I still don't drain them. And I don't drain the back either.
I think I cut out before when I was asking the question about lymphatic massage. Do you have thoughts on that, or did you already cover that?
I haven't covered it and I don't do it.
Okay.
I've had patients do it on their own, and I don't tell them they can't, although I tell them to wait a few weeks because I don't want to disrupt my sutures and I don't want to create friction underneath the flaps, which will lead to more fluid collection and then a higher instance of seroma in my mind, although I thankfully haven't had that happen. But if they want to do lymphatic drainage, I tell them they have to wait a few weeks, 2 to 3 weeks.
Are you using PTS in your circumreferential tummy tucks?
Sometimes.
Okay. Jason Leighton's asking, he says—
You're talking about the posterior part, right?
Well, let's see. The question is kind of vague. It says,
okay, so I always use PTS on the front. And then since the posterior part, we don't undermine, we do the caudal resection and then we do the excision, take away the intervening tissue. We don't undermine going up the back. Like going a cephalad direction in the back. We do not ever do that. We do liposuction extensively though. And yes, we'll use PTS or progressive tension sutures occasionally. We do like them. It sets the incision. It obliterates empty space.
Okay. Now, Jason Lycan is saying you might have a lower BMI and Caprini score population than the average doctor or others. Do you feel that it's still safe to use progressive tension sutures in a higher BMI and someone who's using, for example, Lovenox?
So the answer is yes and yes. I don't know why using Lovenox, I'd love to listen to Jason why. Are you concerned? Is he concerned about post-operative bleeding and then creating a seroma? I don't know if that may be what he's thinking about. We do have people who have done this technique with routine use of Lovenox. I've talked to people. And yes, I think our Caprini scores are a little bit lower. I would still use this technique even with a higher Caprini score though.
Okay.
The real question I'd ask is why do a person with a higher Caprini score and increase your risk?
Right, exactly.
That's the real question, not how you do the tummy tuck. It's why would you do the tummy tuck?
Right. Well, and you said you've had a few PEs, but you've never lost one. We've done a bunch of these GEMS and journal clubs where I've asked the question pointedly. We've had Chris Panucci on talking about VTE, and there's a fair amount of people who've lost a patient to
Yes.
to VTE. So yeah, we always want to be careful there. So Dr. Osmi
Froze again.
Dr. Stevens, I'm sure if I come through, I was not worried about the whole Lovenox issue for that there. I just know it's one of the things, the Cabrini score, it's more of the higher BMI patients with the potential for seroma. Lovenox, just because I know we talked about it a little bit earlier in terms of higher Cabrini scores. And no, yes, I'm with you. I don't want to do a abdominoplasty in a patient with a real high Cabrini score, but just in terms of, it was more the Lovenox risk in there. If that was something that someone had someone a little higher, so they would give them Lovenox, if that maybe would, I don't think it would, but just, it was a general.
Yeah, it's an excellent question, Jason. And I think the only way I could answer is would actually do a prospective study or even a retrospective and carve out the Lovenox patients from the non-Lovenox patients. And I don't have enough Lovenox patients to comment, but I'm sure there are people here that routinely use it, and there may be some non-drainers amongst us. And progressive tension. Again, it's not just not using a drain. That's the thing I have to keep reiterating. It's not using the drain and using progressive tension sutures. I'd love to see that study done though, Jason.
Yeah, I would love to have an average BMI of 24 for my abdominoplasties, but I think that when I go to add progressive tension sutures in, I will start with the lighter patients rather than the ones who get to that BMI.
I think that's a great idea.
The right way to
progressively check it out and try to then go up a little bit higher to 26, 28 and so forth. let me know how it goes.
Will do. Thank you.
Thank
Grant,
you, Jason.
George Sanders is asking a great question. We've talked a lot about the positive aspects of progressive tension sutures. Is there any downside, any problems, any negatives, any cautionary tales that you would impart to the viewers today?
So initially the downside is time and just getting used to doing it and spending that extra 15, 20 minutes in the OR when you're putting them in. So that's the first downside. From an expense point of view, it's basically equivalent. You got to either buy 2 drains or buy a few sutures. I'm not sure exactly how that all works out. Post-operatively, if you do have some puckering, you have to do a little hand holding, or you have to talk to the patient, or you have to flick them out, as I've been mentioning. So that would be a downside. I can't think of any others, George, off the top of my head.
Okay. We had a follow-up from Jason Leighton about how long you keep your patients in binders.
Yeah, only the first week.
Just a week.
Now, if we do extensive liposuction, especially if we move it down onto their thighs and so forth, we just put them in a standard lipo garment. And then the binder is discarded still in about a week. As all the docs here know, some patients become binder dependent and may love to have the binders. I encourage them to use panty, the panties that have the compression, and or switch to a body shaper type garment. Someone asked, George asked about what about using PTS with drains? As I mentioned, I would do that. I guess that'd be the only time I would use drains, in case I was closing and it would just oozy. But a good question, George. I've actually not done it, but as long as you were clever about how you put your drains in laterally and equally clever in removing it without disrupting your sutures, I can actually imagine how you could do that. I think I'd come laterally and kind of up and around and then drop it sort of towards the umbilicus, so not to disrupt my periumbilical stitches, or just right underneath, or maybe just instead of a suction drain, maybe you put in a Penrose or something. I've never done that. Or short JP maybe.
Well, Dr. Stevens, I think that's what we're nearing the end of the hour here. Unless there are any final questions, I'd welcome you to offer us any final words of inspiration or insight on drainless tummy tuck that you might want to share, and to thank you so much for taking time to join us. And the international community thanks you. We thank you, and you're just so wonderful to give us your time and all of your expertise. So thank you.
No. The pleasure's all mine. You know, I enjoy it. You called me and asked me to do it, and I said, love to do it. It's so much fun for me to see my colleagues and have the opportunity to speak to them. I miss them, and I miss the meeting so much. The Aesthetic Society meeting was great. What I would like to take this opportunity to do is encourage you to go to my my podcast, The Technology of Beauty. And you can do it on YouTube. I also have a website and Instagram, The Technology of Beauty, where I have the opportunity to interview the movers and shakers of the beauty business, including the leaders in our field. I just interviewed Fuad Nahai, and then subsequently Renato Saltz. Robert Singer's going to be on in a couple of weeks. We have industry titans. We have financial people. We have inventors. We have Jean Carruthers. I interviewed last Friday. She's going to be coming in. She wrote the first paper on Botox and was the second patient to ever have Botox for cosmetic reasons. Sometimes she's credited as the inventor of it. And we have a number of other people all teed up. We have it come out every Tuesday at around noon Pacific Standard Time, and also have them all backlogged. There's about 36 or 37 right now on the Instagram and also on the website and on YouTube. And I'm open to suggestions of having guests. So if you have guests you'd like me to interview, people you know in our business, in any part of our business, please drop me a line at just Instagram is Dr. Grant Stevens on Instagram, or my email is drstevens@hotmail.com. And I'm open to any and all suggestions. And if you'd like to be on, and you can make a convincing, compelling case why you should be on, you will get on. And
Well, I've chatted it into the chat box, Grant, and we're getting questions about how they can contact you. That's a generous offer to have people on. I have a couple suggestions I'm going to get to you offline about, and I'm glad
Perfect.
you're having Dr. Carruthers on. She's fantastic. Thank you so much. It's been wonderful. You are, a leader in our field, and you continue to inspire us. So thank you again.
Thank you very much. See you, everybody. Stay
Thanks,
safe. I
everyone.
can't wait to see you.